Hello everyone, I'm Jeff Walker. Welcome to today's webinar entitled Neurokinetic Therapy, What You Need to Know. Joining me today is Neurokinetic Therapy International Instructor, Dr. Kathy Dooley. But first, David Weinstock is the founder of NKT and also the author of the book Neurokinetic Therapy, an innovative approach to manual muscle testing. In his book, he describes NKT and teaches us how we can help relieve pain and also correct dysfunctional movement patterns. You can find out more about NKT after the webinar, so please hang around and listen to what Cathy has to say today. You can visit the NKT website for more information. You can see the web address there. On there, you'll also be able to see details about the upcoming NKT workshop in Sydney and Melbourne. So if you like what you hear today, there is an opportunity to take it a little bit further. For now, though, we have the great pleasure today to speak with Dr. Kathy Dooley, who's one of NKT's international workshop instructors. What we're hoping to learn today is a little bit about Dr. Dooley's background, how she came to learn about NKT and the journey that led her there, and what we can expect at the upcoming NKT workshops in Sydney and Melbourne. First off, Cathy, I know that you run to a very hectic schedule. It's just gone 5:30 there in New York. Can you start off by sharing with us where you are based and where you have taught NKT over the last several weeks? Over to you, Dr. Dooley.
Oh, thank you, Jeff. My name is Dr. Kathy Dooley. I have taught neurokinetic therapy for quite some time. I started off here in New York City. This is where I practice and teach. I teach for several schools with gross anatomy, so I have a really good background in anatomy, which definitely led me to NKT. Dr. Perry Nicholson got me started, and after I caught NKT fire, I decided to become an instructor with the invite from David Weinstock. I started off in St. Louis. I went to Toronto several times. I was in Toronto last weekend, the last 2 weekends actually. And I've been to Las Vegas, Philadelphia, the United States, as well as various other cities in the U.S., including outside the U.S., London. I've been to London twice. I teach in NKT's levels 1 and 2. And now I'm very excited to come to Australia this weekend, or Sydney and Melbourne the following weekend.
All right, fantastic. Thanks, Cathy. So we did have David on here a couple of weeks ago, and he kind of outlined to us a little bit where the name neurokinetic therapy came from and how it evolved over time. What do you see as the primary difference between NKT and other therapies that it has been compared to?
Yeah, it gets compared a lot to different types of manual muscle testing, everything from an orthopedic neurologic exam with basic muscle testing for strength and muscle testing used in techniques like applied kinesiology. The way it's different is just so infinite, but I'll start with the simple. Neurokinetic therapy utilizes muscle testing as a way to find relationship patterns via proprioception in the motor control center. So we look for links and relationships in faulty movement patterns based upon touch and testing. Just a little bit different than the way it's used in other therapies, especially ortho neuroexams. It's used for measurements of strength against a tester, whereas we look for as light a testing as possible to look for possible compensations in human movement. NKT does have a basis in some of the principles in applied kinesiology, like therapy localization and relational inhibition. And that's pretty much where it ends as far as relationship patterns. We watch the way people move. We watch human movement and look for compensation patterns in human movement with muscle testing accessing the motor control center to initiate change.
And would you describe NKT as more of an observational strategy or technique, or an assessment technique, or a treatment tool, or do you say that is a little bit of each?
Yeah, my answer to all those would have been yes. I use it to look for compensations in movement patterning. I use it for assessing and using it for correlation between my other studies as far as observational skills, and I use it for treatment as well. So I would say if it's within your scope of practice, please use it for treatment. If not, you can still use it for assessment.
You have a background in movement, so is this a big advantage to you knowing NKT, or does this supplement what you know?
I would say yes. Not only supplements what I know, it has definitely enhanced what I know through observational skill. When you start to look at the anatomy and start to look at how synergists and antagonists work and functional lines work, it sort of made things come alive for me. I know I had studied anatomy, trained like everybody else on the planet that's in human movement. And to me, NKT finally made it all come together and make sense and make it applicable to me. And so, I found that NKT definitely not only enhanced, but put me into the next level of understanding.
Jason says he's done some kinesiology training and it always feels like he's fudging it or making it up. How does... do you have a specific strategy or a recipe for the muscle testing that could overcome that?
We do, actually. And mostly, I think that people have a tendency to not go light enough and to make the muscle testing a competition between themselves and the patient. And what you'll start to learn is you observe them move, you have a certain postulate upon where you're going to go for your muscle testing, and then you corroborate said assumption with the muscle test. And most of the time I find that people are either going to way too light, or they're simply not looking for the relationship that matches the human movement.
I think I know where Jason's coming from, but we can go into a nutrition store sometimes and someone will do a muscle test and tell you which vitamin you need to take based on that testing.
Oh, yeah.
So I think he's coming from that point of view. And with the testing, is there a series of tests that you do in an order, or it's based on what is presented in front of you?
A lot of people do test in order, especially like things with the shoulder. There's something called the arm clock where you can test certain muscles within a relationship pattern. Most of the time, you get a pretty good assumption of where you're going to go by actually watching them move and looking for certain glitches and going towards it there. Let me give an example. Like if someone has a femoral acetabular impingement syndrome, and I know that the obturator, internist, and externist are usually facilitated and tight in those type of situations, that I know to go after them as probably being a compensator in human movement. Just by history, it can lead you quite a bit. And where you go as far as, history, you can start to really listen to your client or patient, and they'll pretty much tell you where to go if you just pay attention. But we don't. I have seen people with applied kinesiology backgrounds use muscle testing as a means for choosing nutritional therapies. I must, state for the record that is not what we do at NKT. We are looking at human movement and only movement. And
do you test through different ranges of motion as well?
Absolutely.
And does that coupled with what we'd call a typical posture evaluation, looking at leg length differences and pelvic rotations and things?
Yes, sir. It should be married to your other assessment techniques as a tool for being able to rule in or rule out certain diagnoses or hunches even towards your assessment.
Do you see patterns? If you see someone walk into your clinic, do you kind of look at them and go, aha, I can do this already?
Absolutely. You certainly watch them move. And let me give you an example, too, of that. If they tell me they have pain upon sitting, I'm absolutely having them sit and watch their strategy for sitting or their strategy for going to sit to stand or stand to sit. And already in your mind, you're starting to watch them move and say, I better look at that with NKT and look at this relationship pattern. And it usually gives you quite a bit of help.
Okay, fantastic. And insofar as the application of the technique, how long are the sessions generally?
That's dependent upon the individual using NKT. I speak to some chiropractors that only have 10 minutes with their patients, so they can only use NKT very quickly as part of their assessment for 10 minutes. I spend an hour with my patients, so I can get a lot done with NKT in an hour, but also I'm doing other things like assessing human movement and treatment. So it's really dependent upon the user. And to be honest with you, that's what I love about it, because you can do one muscle test that you have really found a relationship by watching them move or based by history, and still get a lot done even though you don't have a lot of time.
I was going to ask, what do you like most about NKT? And I think that sums that up very nicely.
It does.
And is there any special equipment that is needed or used?
No, I mean, a table is always nice, but sometimes you're in a situation where you don't have it. So I have used NKT in a variety of situations, and it's never let me down. You need no equipment other than your own brain and probably your manual at first.
So the workshops that are coming up this weekend, I know a number of people that are going. What sort of preparation do they need before going to a workshop like that? Is it? Would you recommend it for someone straight out of college, or is it someone with a bit more experience?
Oh, I think both benefit. People that are straight out of college tend to know their anatomy pretty fresh, which is always lovely. But for my people that are more seasoned, it is a nice reviewer course on relationship patterns between synergists and antagonists throughout the body, functional opposites. These things are definitely brought back into the forefront if the practitioner has gotten a little bit accustomed to doing things a certain way. It certainly does throw them a curveball and forces them to think about the anatomy again. I get that feedback a lot. Like, Dr. Dooley, you've made me open my anatomy textbook again. And that's something, as an anatomy instructor, I like to hear.
So from the sound of it, brush up on anatomy and definitely get to revisit at least the antagonistic and synergistic relationships between muscles.
You got it.
That would be useful.
That would be extremely useful. If you get the manual in advance, if you've already gotten the textbook, which is sort of like a manual, it's nice if you want to watch some of David's videos on YouTube just to get an idea of the flow of the course, so your expectations are set. It's quite a lovely time, and even if you don't feel like you have the time to prepare for that, it's a learning process at the seminar, and you're not getting certified at the seminar. So, just come and enjoy yourself and really, be open to learning. Come with an open mind, which is always nice. And if you want to study the anatomy in advance and the relationship patterns between the antagonists and synergists, that is wise and welcome.
Fantastic. Ian's got a question here. How do you think therapy localization actually works? Does it temporarily inhibit or reinforce the compensation?
I think it temporarily reinforces the compensation. I think that's probably the best way I've ever heard it put, Ian. Very, very nicely done. I can't wait to meet you at the course. It's kind of waking up the proprioceptive connection between two areas to see if there is a compensation pattern.
Is NKT only applicable to people who are neurologically healthy, so i.e. those not afflicted by MS or Parkinson's?
Yes, I get this question a lot. It's a great question. With MS being an upper motor neuron issue, as well as Parkinson's being a definite upper motor neuron issue, it is more challenging. I'm not saying that you can't get work done, because these people still ambulate. Unless they are frozen, they are still ambulating. And I do find that NKT can still be tested and helpful. It is a little more challenging to get what we call a neurological lock or a neural lock whenever we're doing muscle testing, because you have to gauge it upon what's a neural lock to that patient. So you may have to modify your testing, but if they're still ambulating, they can still be NKTs, in my opinion. But it is more challenging.
Now, Andrew's got a detailed question. This will draw on some neuroanatomy. And Andrew asks, if the assessment is similar in nature to applied kinesiology, what is the treatment focused around? Is it more spinal reflexes, neurolymphatic, neurovascular points, or meridians?
Ooh, I'd have to say yes to all those too, depending upon your, those things are not different things. We like to think that lymphatic channeling and acupuncture meridians and circulation, those things are not different. Those things lymphatics are absolutely demanding muscular and neurological control in order to even be pumped back into the venous. So those are not separate entities. That's A. B, yes, the homework is something we discuss at the seminar, and it's really, really effective. We look for whether you treat a compensator with dry needling or lymphatic changes or active stretches. There's different types of methods. But what we look for is for those methods that you chose to be able to create a neural lock on a muscle test. And so if that's able to be done, then you can proceed with treatment. But yeah, I'd have to answer yes to all those. Those are all possible modalities for treating a compensating pattern.
Does your approach change for a chronic versus an acute injury?
Ooh, that's a great question too. These questions are amazing.
We're very bright down here.
I can tell. I'm very excited about this weekend. And I say that sometimes yes. With an acute symptom, the number one issue is usually this inflammatory component, the swelling component, and pain. And pain alters all motor control. So in an acute situation, I kind of like them. They're a little easier because the pain usually, if I can get it to dial down through the muscle testing, then I have an immediate response and I look like some kind of magician. But really, I'm just trying to reestablish a muscle or a different relationship patterning between two structures. With the chronic case, of course, we see those. I see those a little bit more. People that have been dealing with pain for a while and then sought treatment. Absolutely very effective. Your detective work goes up a little bit with chronic cases because there may not always be pain. It might only be positional.
Oh, Andrew said magic, thanks. And Karen immediately follows with, what is a neural lock?
Oh, okay. So a neurological lock or a neural lock is when you get a muscle test that is I don't want to use the word strong, but a muscle test that's able to be maintained by both the tester and testee in equal parts. So that there's no amount of shiver in the movement, there's no global compensations that you can visualize or feel. So you're able to maintain a neurological connection between tester pressure and testee pressure.
Perfect. Very nice. Very nice explanation. What would a regular NKT session look like? So what's your clinical reasoning when someone comes in and says, I've had low back pain that flares up and down? What sort of process do you go through? What's your clinical reasoning to get to where you need to be?
Well, first I have to put them through the movement that causes them pain. So I watch the way that they do that. I'm assuming you say all neurological and orthopedic testing aside, the fact that I've already probably put them through an ortho-neuro exam. When I'm going through with the NKT, I use the findings that I have discovered through other testing, and then I kind of let that guide my NKT. And so let's say if someone has extension intolerant low back and they use their low back as a fulcrum for movement, I would assume, this person cannot use their hips. Maybe I should look for a hip muscle that's compensating for a muscle that's stabilizing their low back. And so that's how I would use my NKT to guide me. And so I would start to look for those relationship patterns.
Do they get homework to do before and after the next session if that's required?
Oh, you betcha. Here's the thing, is that I don't like passive treatment. I think that it only works a little bit. And I think what I can teach the patient or client to do for themselves ultimately matters most. And so that's where NKT really shines, where you have a very good way to assign correctives for the client to do at home to break these patterns that cause them to hurt themselves. And I think they find it very empowering. My patients don't see me all that often, and I think they like the fact that they're in charge again, that they've taken control over their pain.
Do you teach them before they leave your clinic, or do you send them videos or give them a handout sheet, or how do you...
Yes, actually. I'm not trying to be vague. Those are actually all the things that I do. When they are in the office, I coach them through the homework. I videotape it for them and put them up in an online server called Dropbox, where they can access it anywhere they are in the world. And then I send them an email list of the correctives where they perform things in certain orders. So they get all three of those within 24 hours of the visit. They have all that waiting for them.
Okay, and I assume we'll be going through that in the workshops in Sydney and Melbourne?
We sure will.
Fantastic. Also throughout videos online and throughout David's book, there's a lot of mention of inhibited and facilitated muscles. Can you just explain that to us in a little more detail?
Yes, for lack of a better term, we use the words facilitation, and then we also use the term inhibition. Facilitation is a muscle and a pattern that could be compensating. The inhibition is a muscle that is being overridden by the facilitator.
With that, do you have that you have the no pain, no gain sort of clients? Do you have a different sort of conversation with them? If you're telling someone that's inhibited or it's weak, for example, that sounds like a challenge to them. Are you careful with that?
Be careful with that language. I don't use the word weak ever. I might use it with my testers, people that are testing people, but I never use that word with my patient. The patient hears the word weak and they think that they have a competition to win. And so, but if you tell them that, I mean, there's a plus side to that. They tend to compensate like crazy and you find it all. But they can try to win, but that doesn't mean they will. But yes, you do have to have those conversations with the client. You have to say, I need you to meet my pressure on this test. And, the softer you test, the better off you are. And you'll see that in the seminar, that the testing is a lot lighter than you might think.
So just to work out whether there is actually a connection there or not.
Yes.
Is there any sort of pin and stretch that you do, like ART?
Oh, yes. I mean, I'm ART certified, full body and nerve entrapment, but I can't advertise that because my certifications, I have to recertify in June. But I would definitely call it pin and stretch. You don't have to use that. You can use dry needling, you can use acupuncture, you can use gua sha, twang na, massage techniques. It doesn't necessarily have to be pin and stretch, but that's just something I utilize.
Peter's asked a question, insofar as we mentioned lower back pain earlier. I actually know Peter. I know he gets some low back pain. He doesn't get it all the time, though. So during an assessment, will NKT be able to pick up what's going on if there's no pain on the day?
Absolutely. Most of the time, even if there's a dysfunctional movement pattern, if they have pain in their history, you can elicit it during the session, or at least elicit the discomfort that's similar and put dysfunction into the system so you're able to test it. But if that's not the case, if it's too transitional, then you can still look for movement patterning in where they get the pain. So if they say, oh, I get the pain when I do this, just watch them do that and it will guide your.
Andrew's gone for a heavy-hitting question here. For corrections, would you find that you are able to benefit vestibular imbalances, esophageal sphincter, i.e. reflux, and non-secondary fascial release?
Yeah, all those things. With the vestibular, a lot of that's based upon eye movement. For the vestibular ocular reflexing, vestibular spinal reflexing is still dependent upon eye movement. So there's a lot of things. It's actually NKT level 3 where we discuss a lot more of the vestibular movement or vestibular apparatus and eye movement. But level 1 is it doesn't deal with it nearly as much. We look at eye movement as a compensation pattern. But if you're dealing with things like Meniere's and other types of disorders that are vestibular in nature, it can be, of course, challenging, just like the MS and Parkinson patients are challenging. It doesn't mean that there's not validity and ability to be able to use NKT in those cases. In fact, I found that I am more effective in helping someone with Meniere's than I use. Yeah, helping them understand too how eye movement affects their movement can be very helpful, especially when they see a muscle test change with NKT.
On the levels there of the NKT workshop, what gets done in level 1 versus level 2 versus level 3?
Level 1 is definitely foundational muscle testing. It's muscle testing of each of I say muscles, but they're really patterns, of course, but basic muscle testing philosophy with NKT and going over each of the tests as separate units. That's a full weekend, by the way. That's a very full time. Level 2 is really exciting once you've gotten all the muscle tests down and started to look for relationship patterning. Now we go into more of the patterns. We talk about subsystems, gait, functional opposites, perturbation, jaw. We go deeper into the intrinsic core. So once you develop your foundation with NKT, you can expand it and even make it easier to do with level 2. And then level 3 is more complicated movement patterning, like eye movement, overhead squatting, rolling, Pavlov press, the like.
Must say, I'm really looking forward to it. There's a lot more to it than there seems to be on the surface, which is, I guess, it's why it's slowly but surely making its way around the world.
It is.
Yes, and you seem to be leading the charge.
Not so slow, Jeff, when you're the one doing the traveling.
That's true.
Not that I'm complaining, I'm having an absolute blast, and with each class, there's always this hesitancy of what the heck is NKT anyway? As good as we try to describe it, there's only one way to experience it, and that's in person. So I hope that people, like in Australia and around the world, take the opportunity, if you're anywhere near, go to a seminar, and if you're not, then get near. Make your life easier. It's made my life infinitely easier as far as my diagnostics and assessment.
Well, that's pretty powerful because you're very well educated. So
Thank you.
That's quite a thing coming from you. Pain. Will we experience any pain having NKT treatment?
During muscle testing, certainly. If you have an underlying issue of compensation, I bring it out. There could be some discomfort. There could be tightness perceived, which is usually common. Cramping can sometimes occur, but no pain that you will get off the table with, hopefully. I mean, no new pain, but you never know what's going to happen in human movement. You start messing with the motor control center and start trying to change movement, and things do occur, but I've never had a negative experience with NKT, which is also a powerful statement, because I know that negative experiences are kind of expected. But if I'm using it wisely and using it smartly, I don't have to worry about that patient leaving with more pain than they came. So don't be too worried.
No, we're all tough. And where you see muscles that are often facilitated and muscles that are often inhibited, are they pretty common and pretty easy to identify? And do you see them occurring in patterns? You have a list.
Sure, yes. Yes.
So what would be some classic facilitated muscles?
Yes, we have basic patterns for you. Although there are no absolutes, we'll have some basic kind of cookie cutter ways to think about things, and then always keeping in mind that there are no absolutes and that there's a possibility for things to go awry and be on an inhibited list when they usually are on a facilitated list.
Okay. So what would you say for a whiplash injury? What would you expect to see inhibited versus what would you expect to see facilitated?
It depends on the type of injury in whiplash. It depends on if they were struck from the front or behind. But the large tendency with whiplash is a facilitated posterior neck and posterior back, and inhibited flexion patterns like cervical flexion and lumbar flexion. But I'm being very vague, of course,
Yes,
because I want to test that.
Yes.
But yeah, that's typical in a whiplash injury.
Part of the premise or part of the physiological process of NKT is that you're affecting the motor control center in the cerebellum.
Yes.
Can you just explain that a little bit for us as well? That was another thing that came up in the last few days.
Sure. Just keeping in mind that the motor control center is not only cerebellum, but is largely mediated by cerebellum, first off. But we do consider motor control center to be in cerebellum, even though it receives connections and sends out connections to various places. Motor control center is basically how we're going to be coordinating human movement. Cerebellum being the coordination center of the CNS, it's largely important for input, proprioception, receiving the input, and then trying to find out what to do with it. So hugely important in being able to establish motor patterning and also being able to carry it out.
Okay, fantastic. And Judy has a question for you here, it's actually a very good question, which most of them have been. Does palpation have a role in NKT?
Huge, massive, great question. Yes, hugely important. And I will definitely show you how knowing your anatomy on palpation is going to be very helpful with therapy localization, the way that we test in NKT, and also the way you treat if you have the scope of practice to do so. Very, very important. But if you're struggling with palpating certain structures, definitely let me know at the seminar. And I can help guide you as far as the anatomic location of things. But palpation is huge in NKT, very important.
And Karen, obviously from Northern England, says, do you have any courses planned for Northern England?
Oh, well, we have London. David Weinstock's going to be in London for level 1, 2, and 3. So you'll have to come to London. That's the only place we go in England right now. Sorry, Karen. But it's worth the trip. It's, you need to go to London every once in a while anyway. Now those floods are over. Just go there, have a good time. My wonderful colleague, Robert Cavanaugh, is usually the host, but David will be teaching, and you will not regret it. I know I flew to London for my level 2 last year, and changed my life, obviously.
Andrew asks, on whiplash, do you find you have to dig a little deeper than standard relational inhibition, semi-hypertonicity?
Sure. I think that with acute whiplash, I'm assuming he's talking about when they just walk in, there's certain stabilization that probably needs to happen in the cervical spine. So you may not use NKT on that first visit. Some people do. I know David probably does. But you want to develop your skill set to make sure that you accommodate for that hypertonicity. Yeah, you're in whiplash. Those cervical extensors are tight for a reason. They just experienced something traumatic and maybe are tight for stability, and so I'd be careful trying to release that. So you'll find in NKT we just don't release for the sake of releasing, which is what I was doing forever with my active release technique skills. And I was just, that hip is tight, let me release it, and not even being responsible with why I was releasing something. So you might find that with an acute whiplash, you are actually doing a minor amount of releasing and more stability work, and NKT might be able to help you.
Oh, is this another one that leads on from that? What further balances for reactive muscle sets might you use with NKT? That's in relation to
that's a hard question to answer because there's so many muscle resets. You can use reflexive neuromuscular stabilization. You can use exercise, which I use very readily. You can use integration patterns through things like deadlifting, Turkish get-up. You can use biofeedback. You can use ADL, just basically training their activities of daily living. There are so many modalities. I'm not there to teach modalities. I'm there to basically just teach assessing. I've seen people do such good work from acupuncture to massage to osteopathy and chiropractic. And a variety of different techniques for being able to integrate these patterns of now proper movement. So I have to say that's a tough one to answer because there's so many. But I'm not there to teach you that. I'm there to basically just teach you the assessment. What you do with it's going to be your call.
Which is your catch line.
Well, it's my catch line for a reason, Jeff. It's the truth.
Yes, it certainly is. All right, thanks for that, Andrew. Hubert's got one. We might have to make this our last question, unfortunately. Does NKT allow you to differentiate between hypertonic or tight and taut muscles?
Yeah. So he's talking about a tight and inhibited versus a tight and facilitated muscle?
Yes.
That NKT is the only way I've been able to tell that. I mean, I can assume some things from posture and the way that they move that, if their shoulders are rounded forward, then their infraspinatus might be tight and long, or their rhomboids might be tight and long and inhibited. And I can postulate that, but then when I put them on the table, does this matter in their execution of human movement? Does this matter in their pain and how I can help them? And NKT helps me to decide yes or no.
It's been wonderful speaking with you.
Oh, it's been great.
Very nice to electronically meet you. I'll be at the course on Saturday and Sunday, so I'm really looking forward to meeting you and you sharing what you know.
Yeah, me too.
Oh, fantastic. So the slide you have on the screen at the moment, everyone, are details about the upcoming workshop with Dr. Kathy Dooley. That will be on the 1st and 2nd of March. So if you feel that you need to gather some more knowledge in this area, based on what Kathy's shared with us tonight, by all accounts, I think it's going to be a very, very comprehensive workshop. I've had some communications with Cathy via Facebook over the last several months now, actually.
Mm-hmm.
So with that, I'd like to thank Cathy for her time this evening and thank her also for adding to the kilobytes of information in our brain that are now going to make us better therapists.
Nice. Very nice. Thank you so much for having me. It's been my honor to be able to share this with the United States and now the world. So I'm very excited about helping out in your continent.
Definitely. We'll look forward to seeing you on the weekend. Thank you all for tuning in tonight. And we'll see you real soon.
Thank you.